All right, so last time we made our way through the oral cavity and down to the stomach. We're going to finish off the stomach today. We'll talk about the different cell types that are responsible for secreting various components of gastric juice and their importance. We'll talk about how gastric secretion and stomach motility are regulated. We'll talk about the alkaline tide and how that occurs when we make hydrochloric acid. We'll talk about the liver and the pancreas, bile and pancreatic juice, the gallbladder, and then we're going to end with some hormones with the pancreas and small intestine regulation. So the stomach temporarily stores foods and begins protein digestion. So the digestive processes that occur in the stomach include propulsion, so it's going to be moving food forward. And the stomach, if you remember from last time, has a third extra layer of smooth muscle to help it do that. What is that extra layer called? The oblique layer, yeah. So every part of the GI tract should have the circular layer and the longitudinal layer as part of their muscularis externa tunic of the GI wall, but the stomach has the oblique layer as well. We have protein digestion going on in the stomach. We go from peptides, which are short protein segments, into its monomer. Now, what's the monomer of a protein or a peptide? Amino acid. The stomach is responsible for making intrinsic factor. Intrinsic factor is needed for vitamin B12 absorption. So without intrinsic factor from the stomach, we can't absorb B12 from our diet, and we need B12 in order to produce healthy, mature red blood cells. So with alcoholics, they have a lot of stomach damage and fibrosis, so they don't make as much vitamin B12 as somebody who does not have fibrosis in their stomach. And so what ends up happening with those people who don't have enough intrinsic factor and therefore are not absorbing enough B12, they have fewer, larger red blood cells due to the decreased production of that intrinsic factor, and they end up with essentially immature red blood cells. And does anybody remember the type of anemia that causes? Pernicious anemia. The treatment for that is either a nasal spray or an injection of vitamin B12 if they can absorb it themselves. There is a little bit of absorption that happens in the stomach. It really is just lipid-soluble substances, and that includes alcohol and aspirin. So that's what's going to be causing the damage in the stomach due to the alcoholism or alcohol intake. One thing I do want to mention, though, about the intrinsic factor. This is the only essential to life function for the stomach. Because without the intrinsic factor, we can't absorb B12, and then we don't have mature red blood cells, which means that our oxygen delivery is going to be compromised. So any questions about the digestive processes that are happening in the stomach? Okay. What is the one and only digestive process that's happening in the esophagus? Just propulsion through peristalsis. That's it. So we do have quite a few cells in the stomach. We're only going to talk about 3, though. So there's a little T-shaped chart in your lecture notes. On one side, you're going to put the stomach cells. So we have different cell types that we're going to talk about. And on the right side, you're going to put the product of those cells. So the first cell type of the stomach you have to know are parietal cells. And parietal cells produce intrinsic factor that we just talked about, plus hydrochloric acid, which is essentially hydrogen ions and chloride ions. And that makes hydrochloric acid. Now, the production of hydrochloric acid specifically, this is triggered by a few different hormones and chemical messengers. So this is triggered by what is the neurotransmitter for our parasympathetic nervous system for rest and digest? Acetylcholine. So that's one of them. Also gastrin, which we're going to talk about in a second. And then also histamine. So they can all trigger the production of hydrochloric acid. If we have all three present, then we have a really big increase in hydrochloric acid production. So what kind of interaction do those three chemical messengers display? If we have all three present, then the amount of hydrochloric acid increases exponentially. Synergism. The next cell type is something called a G cell. Now, it belongs to a group of cells called enteroendocrine cells, which is essentially just endocrine cells of the GI tract. But we call it a G cell specifically when it produces a hormone called gastrin. So G for gastrin. So we have enteroendocrine cells that make different chemicals and hormones for the GI tract. But when it makes gastrin, we call it a G cell. And then that gastrin binds to parietal cells to get it to produce hydrochloric acid. So if these are both cells of the stomach, one signaling the other to produce that hydrochloric acid, what kind of chemical signaling is that? Paracrine. They're both in the stomach, they are right next to each other, and one signals the other. And then the last cell type, that you have to know is something called a chief cell. Chief cells produce something called pepsinogen. And just like when we talked about fibrinogen and angiotensinogen, that means that's the inactive form. So pepsinogen is the inactive form of a protein enzyme. When it gets activated, it turns into pepsin. And pepsin is an enzyme for breaking down protein. Now, what's going to trigger the movement from the inactive form to the active form is that hydrochloric acid that we just talked about. So as soon as pepsinogen encounters pH levels that are really low, like the acidity in the stomach, that's going to trigger it to go from the inactive form pepsinogen into pepsin. So it interacts with hydrochloric acid, and it's really the drop in pH that causes the conversion from pepsinogen into pepsin. And then pepsin is a hormone, not hormone, but an enzyme for protein digestion. So questions about those three cell types and products?
Pepsinogen is the inactive.
Mm-hmm. Yes, pepsinogen is inactive, pepsin is active. And it's really important that these enzymes are in the inactive form inside the cells that they produce. Because if it was inside the cell as pepsin, then that pepsin would start breaking down all the protein that's within the cell. So we have to keep it in that inactive form, pepsinogen, so that when we release it, then when it's in the lumen of the stomach where the food is, then it can be converted into pepsin and then break down the protein. We don't want it to break down the protein while it's inside the cell that it's being made by. They would, yeah. All right, so this is just showing you all the different cell types of these gastric pits that I briefly mentioned last time. So we have gastric pits that have your normal epithelial cells, a simple columnar epithelium, and then even below that, there are gastric glands with all these specialized cell types that make all these different products or secretions. So we described parietal cells, chief cells, enteroendocrine cells, specifically G cells that make gastrin, you do not have to worry about the mucous neck cells. We're not going to cover those. So gastric secretions, the production of that hydrochloric acid is regulated, and it goes in 3 different phases. The first phase is the cephalic phase or the reflex phase. Cephalic means head, and if you remember we talked about before, really just the thought of food or the smell of food or the taste of food, well, more like the brain and stuff. But just thinking about food can cause the digestive activity to begin, which is why they call it the cephalic phase, which has to do with the head and the brain. So the cephalic phase, this occurs before food even enters the stomach. This is when you think about that food, or your brain knows that you're on a certain schedule of eating food and starts that process for you. So this happens before food enters the stomach. Lasts only a few minutes. And the triggers act by the vagus nerve. If you remember from B32, the vagus nerve is the one and only cranial nerve that actually goes into the abdomen and controls our visceral organs. So with this phase, you have the sight or thought of food, or the taste or smell of food. Either one of these things are going to send messages to the cerebral cortex, which is going to send messages to the hypothalamus and medulla, which regulate digestive activity, and then send that message to the vagus nerve. And then that's going to cause, and I'll show you in the next slide here, but that's going to cause the gastric mucosa to secrete gastric juice, which includes hydrochloric acid. That gastric juice is very acidic at around a pH of 2.5. And we secrete about 3 liters of gastric juice every day. And during digestive processes, the vagus nerve would be under sympathetic or parasympathetic control. Parasympathetic, which is your rest and digest. So then the neurotransmitter would be what? Acetylcholine. I'm going to ask you a million times just to make sure that you guys got it. So any questions about the cephalic phase? So this is just the beginnings of the gastric secretions, because you thought about food, it was time for you to eat food, or you actually smelled or tasted food. Before we move on to the next phase, there are some inhibitory events, some things that can stop those juices from being secreted. So loss of appetite, depression, these are things that kind of turn off your digestive system activity when you're not in the mood to eat. Okay. These are messages that get sent to the cerebral cortex when you are depressed or low energy or low mood. And that tells the parasympathetic nervous system to slow down, so then your gastric juices slow down their secretion. The next phase is the gastric phase. So this is all happening within the stomach. This lasts about 3 to 4 hours. The trigger is stomach distension. So this is the swelling or filling of the stomach. And so the stomach stretches. What are the kind of receptors that would detect stretching of the stomach? Mechanoreceptors. So this phase is triggered by the stretching of the stomach as well as food entry. And so the food entry, this is especially true for peptides, which are proteins, and caffeine, are big triggers of this phase. And then also an increase in pH, because the pH of your stomach is very acidic, around a 2.5, but then you introduce new food, put that into the stomach, and now the pH is going to rise. And that rising of pH is then going to trigger the stomach to then produce more gastric juice to bring that pH back down. And then essentially the more protein or the more caffeine that gets brought in, the more hydrochloric acid that's going to get produced. So we have hormone release, gastrin we just talked about, stimulates the parietal cells and chief cells to secrete their own secretions, with the parietal cells secreting the intrinsic factor and hydrochloric acid, and the chief cells producing that pepsinogen to break down the proteins that just entered the stomach. Things that can inhibit this phase are excessive acidity. So our pH in the stomach should be around a 2.5. If it drops below 2, that is too acidic. And then stomach secretions will slow down. So to give time to make it rise back to its normal range. Also emotional stress. If you're under emotional stress, this is going to turn on your sympathetic nervous system, which is going to slow down your parasympathetic, and gastric juices will also slow down in that case. And this is where most of our gastric juice is going to be produced. 2/3 of our gastric juice is produced here during this phase. Any questions about the gastric phase? Okay. Also, another trigger to slow down digestive system secretions is also nicotine. Nicotine could also make you lose your appetite, which will slow down the production of gastric juice. The last phase is the intestinal phase. So this is where we kind of slow down the stomach secretions, because now we're going to move our digestive activity from the stomach to the small intestine, which is why it's called the intestinal phase. We're transitioning from breaking things down in the stomach to breaking things down in the small intestine. What is the name of the first part of the small intestine? Duodenum, or duodenum, whichever way you want to pronounce it. So the intestinal phase is all about just a brief stimulation of producing this gastric juice, and then inhibition right after that. We're just barely making just the last little bits of gastric juice to finish off digestion in the stomach before we move on to the duodenum. So the trigger for this phase is the filling up of the duodenum. As soon as we start filling things up in the duodenum, going from the stomach to the small intestine, then gastric secretions are going to slow down. So we'll briefly trigger some gastric juice to be produced, but then we're going to inhibit it right away after that. So just kind of on and off until we transition to the small intestine. In this case, intestinal gastrin is released. So as soon as a little bit of that fluid in the stomach, which now you should know the fluid in the stomach, that gastric juice is called chyme. And so once that chyme starts to move into the small intestine is going to produce the gastrin that's going to finish off the stimulation of gastric juice secretion from the stomach. But again, it's a brief stimulation and then an inhibition, because we are now transitioning to the small intestine. So you can see here, presence of partially digested food in the duodenum, or stretching of the duodenum when the stomach begins to empty. It's going to cause the small intestine or the duodenum to release gastrin, which only has a brief effect on the stomach, because now we're transitioning. And then the inhibitory side is distension of the duodenum. Again, as soon as we start filling up the small intestine, we're going to be slowing down secretions of the stomach. This is a transition phase. So any questions about the intestinal phase? Okay, so cephalic phase starts it off when you think about it, or smell it, or even taste the food. Then most of it's going to happen during the gastric phase with the stretching of the stomach. As you start to fill up your stomach, more gastric juice is being secreted. And then the last phase is the intestinal phase. Once food starts moving into, or chyme starts moving into the small intestine, then we slow down secretions of the stomach. One other thing that's happening during gastric or stomach activity is we're going to have peristalsis happening. That's one of the functions of the stomach, is peristalsis, or propulsion of food. So how it works is you have propulsion or peristalsis pushing that chyme down to the bottom end of the stomach, which is called the pylorus. And when those waves hit up against the pyloric valve, it's going to, and I hate this word, it's going to squirt a little bit of chyme into the duodenum, just a little bit. Okay, we do not want all of the contents of the stomach going straight into the small intestine, because one thing about the stomach is that it has extra layers of mucus that other parts of the GI tract do not have. So it has protection against this really acidic chyme. Your duodenum does not have that extra protection. So if we were to just put all the contents of the stomach into the small intestine at one time, it would burn through the wall of the duodenum. Okay, because it doesn't have that extra protection. So we just put a little bit into the duodenum at a time. We'll learn about it in a few slides, that the pancreas actually produces bicarbonate to neutralize that acid. So we have to do it in little bits. We can't do it all at one time. So as peristalsis is moving this food down toward the pylorus of the stomach, little bits of chyme squirt into the duodenum. And then once that happens, the pyloric valve is going to close, and then we're going to have what's called retropropulsion, where when it hits up against that pyloric valve that's now closed, that food is going to go back to the top of the stomach. And so it's a constant this way, push a little bit out, goes back up, and this way, and back up. And that's part of how we're going to actually mechanically break down our food as well. And then as that fluid is moving, and we have that pepsin that's in the stomach, it's going to also help to break down the protein that we've been eating as well.
Does that say the churning you mentioned?
Yeah. So any questions about peristalsis or churning in the stomach? Okay. So this is just a summary of all those three phases together on one diagram. All right, so the next is how we produce hydrochloric acid in the parietal cells. So we're going to be using that equation that everyone loves. CO2 plus water is reversible with carbonic acid. Anybody remember the enzyme that does this conversion here? Carbonic anhydrase. And then that's reversible with a hydrogen ion and a bicarbonate ion. All right, you have a blank diagram just like this in your lecture notes. And so what we're going to be talking about now is how we use this equation, this bicarbonate buffer system, to help us produce the hydrochloric acid in the stomach. So we have CO2 and water from the blood plasma gets transported over into the parietal cells, and that's going to start our movement of that equation to the right. CO2 and water, through the use of carbonic anhydrase, gets converted into carbonic acid, and then inside our cells is a bunch of fluid. And acids, they dissociate in fluid or solution. So as soon as we convert it into that carbonic acid, it's going to immediately dissociate into its parts, which is a hydrogen ion and a bicarbonate ion. So what we're going to do is that hydrogen ion, that's half of our hydrochloric acid. Hydrochloric acid is a hydrogen ion and a chloride ion. So we already have half of our hydrochloric acid. So we put the hydrogen ion into the lumen of the stomach. And anytime we move ions, it's usually through either a proton pump that'll move this proton or hydrogen ion across, or some kind of protein exchanger where it will put one ion in one direction and another ion in the opposite direction. In this case, It is a proton pump. And because we never want to mess up with the membrane potential of a cell, so when we lose a positive, we're going to gain a positive into that cell. So we are pushing out the hydrogen ions, and then we're bringing in a potassium in its place using a proton pump. That is half of our hydrochloric acid. Questions so far? And I'll let you write this part of the process down before I move on to the next part. Did you review this stuff?
When it's starting tomorrow and Thursday. I
meant you personally.
Oh yeah,
Yeah.
definitely.
Yeah.
Yeah. This was my favorite chapter.
Digestive, really?
Yeah. I don't know why.
Okay, anybody still need time to write this down? Okay, so the hydrogen ion is half of our hydrochloric acid, but now we're going to take that bicarbonate and we're going to put it into the blood plasma. Okay, if you remember, 70% of the carbon dioxide that we carry is transported as bicarbonate in the plasma. So this is one way that we put that bicarbonate in the plasma to transport that CO2. And then when we need it, we'll just put it in the other direction back into the CO2 form. So 70% of our CO2 is transported as bicarbonate in the plasma. How much is bound to hemoglobin? What percentage? 20%. So then how much is dissolved as CO2 in the plasma? 10%. Don't forget those percentages. So because we just lost a negative ion, we're actually going to, and before we get there, the movement of that bicarbonate to the blood plasma, we call that the alkaline tide. Bicarbonate is a buffer, and it's going to increase the pH of any environment that it's in. So that's why we call it the alkaline tide, because it's putting us closer to alkalosis. It's raising the pH, making it more alkaline. So we call that the alkaline tide. And if we lose a negative, we're going to gain a negative in its place. And the negative that we are going to gain is going to be the chloride ion. And that's going to briefly move into the parietal cell. And then we're going to exchange it again. I won't make you know the other anion exchanger over here. But we're going to have another exchange on this side to put it into the lumen of the stomach. And now we have our hydrochloric acid. And I don't even think that chloride ion at this end, I think it just moves here through facilitated diffusion, but I won't ask you about that. But in case you're curious, this one moves by facilitated diffusion. So just a protein channel that will take it from the inside of that parietal cell to the lumen of the stomach. So any questions about this process? And we'll go over it again on Wednesday. So I'll go through it one more time. So we take some CO2 and water from the blood plasma, transport that over the interstitial space and eventually into the parietal cells, which are in the stomach. And remember that those cells have receptors for gastrin, histamine, and acetylcholine. And if all three are there, we're going to be producing lots of hydrochloric acid. But that CO2 and water is going to interact with that carbonic anhydrase to make carbonic acid, which is going to split into a hydrogen ion and a bicarbonate ion. That hydrogen ion is half of our hydrochloric acid, and we're going to exchange it for a potassium using a proton pump. So we're going to exchange a positive for a positive. And then we're going to take the bicarbonate ion, we're going to put that into the blood, and because that is a buffer and will raise the pH of the blood, we call that the alkaline tide. We're going to be exchanging that bicarbonate with the chloride ion, and that will go from the interstitial space through the parietal cells and eventually make its way to the lumen of the stomach, which both of those things, the hydrogen ion and the chloride ion, will make our hydrochloric acid. But because it's an acid and the lumen of the stomach is a solution, it's gastric juice, it's going to stay in its parts. So any questions on this process? Okay. This is the one from your book. It's a little bit more complicated, but you can see CO2 being brought over, which was originally in the blood, brought over to the interstitial space. It interacts with water to make that carbonic acid, which splits into the bicarbonate and the hydrogen ion. Hydrogen ion gets moved over to the lumen in exchange for a potassium. The chloride moves over to the blood in exchange for a chloride, and the chloride and the hydrogen make that hydrochloric acid. But that's all happening within the parietal cell, which do have mitochondria. And the pepsinogen is being produced by chief cells. That pepsinogen interacts with the hydrochloric acid from the parietal cell, and that converts it to its active form, which is pepsin. Okay. Any questions so far? Okay. So medications that decrease stomach acid include antacid tablets like Tums. Tums is basically calcium carbonate, which neutralizes acid. However, Tums are meant as a temporary fix for indigestion, you should not be taking Tums all day long every day. Because what's going to happen is that calcium carbonate is going to neutralize the acid in your stomach. And now you don't have the trigger to turn pepsinogen into pepsin if you keep neutralizing the acid in your stomach. And so if you're not turning pepsinogen into pepsin, then you're not properly breaking down the protein that you should, and you may end up malnourished because of it, because you're not properly breaking down that protein, because you're not allowing that gastric juice to be at the pH it should be to convert pepsinogen into pepsin. Does that make sense to everyone? Okay. Still in the same spot in the gastric glands of the stomach. Yep. Where are my notes? Okay, yeah, okay. The next thing is going to be proton pump inhibitors, or PPIs, like Nexium and Prilosec, which are for reducing stomach acid and helping with things like heartburn. But it's a proton pump inhibitor. And so what it does is it inhibits this proton pump here. And so if it inhibits that proton pump, not as much hydrogen ions are being put into the lumen of the stomach, and so you're not producing as much hydrochloric acid. It doesn't stop it completely, it just slows it down. We're just slowing down the production of hydrochloric acid. So in this case, we don't have the danger of malnutrition because acid's still being produced, just at a lower amount. Okay, so we're still getting that conversion of pepsinogen into pepsin. And then the last one is Tagament. Tagament is what it's going to do, it's going to block histamine receptors. Is that written in your lecture notes already? Yeah. So it blocks histamine receptors, so you lose one of the triggers that gets those parietal cells to produce the hydrochloric acid. Because like I said before, if we have all three of those triggers present, we're going to be producing a lot of hydrochloric acid. Well, now we've just taken away one of those triggers by blocking those histamine receptors. So we just get less production. Okay. Everyone okay with this? Okay. Next thing is emesis. Emesis is the scientific term for vomiting. So make sure you know the word emesis. This is caused by extreme stomach distension, so overfilling your stomach, or by the presence of some kind of irritant, something doesn't sit right in your tummy. Okay. If you are chronically vomiting, so vomiting frequently, this can cause alkalosis of the blood, because what's happening, we go back to our diagram over here. If you vomit, you are emptying the contents of your stomach. And so that gastric juice has to be replaced. And every time you replace it, you're putting a little bit of bicarbonate into the blood, making the pH higher. So you vomit again, empty the contents again, and then you make more gastric juice to replace it, and you're putting more bicarbonate into the blood. If you do that consistently, you're going to end up increasing the pH of your blood over its normal limit, causing alkalosis. Okay, what is the normal range for the pH of blood? 7.35 to 7.45. So if you're constantly vomiting and constantly replacing that stomach acid, you're going to be putting too much bicarbonate into the blood plasma, causing alkalosis. Does that make sense? Okay. Clinical note on gastric ulcers. We mentioned this a little bit before last time. Gastric ulcers are the erosion of the stomach lining. It's often caused by Helicobacter pylori, which you can abbreviate to H. pylori. 90% of the cases of gastric ulcers are due to this bacteria. That bacteria eats away at the mucus of your stomach. It treats it as food. It has protein, so nutrients for it to grow. And so it eats away at the mucus, but then it gets so far down that it starts to eat away at the actual lining of the stomach wall. And it can eventually cause a perforating ulcer. And if we have a perforating ulcer and a hole in that stomach wall, now gastric juice is being leaked into the abdominal cavity. Chyme is being leaked into the abdominal cavity, and you have bacteria living in your stomach as well. So that could be spreading bacteria all through your abdominal cavity. Okay? And what is that going to cause if you have acid and bacteria all in your peritoneal cavity?
Infection?
Yeah, an infection, yes, but what is one thing we talked about last time that it can cause?
Peritonitis.
Peritonitis, which can eventually lead to sepsis, yeah, if that infection spreads. So this shows the blue here is mucus, so those little blue dots are mucus, and the pink are bacteria, just eating away at that mucus. And that's at a microscopic level. The right is your stomach at a macroscopic level. But they can eat away so far at your stomach mucus and the lining, and eventually cause a hole in the stomach. So next, the liver secretes bile, the pancreas secretes digestive enzymes. So we went over the anatomy of the liver last time through your digestive anatomy lab. So we have a right lobe of the liver, a left lobe of the liver. Can you guys tell me from Bio 32 which of your 9 abdominal pelvic regions does the liver sit in? There's 2 of them. Yeah, so right or left? The right hypochondriac region, which is here. What's at the very top? Epigastric. So those are the 2 regions that your liver sits in. The right hypochondriac region and the epigastric region. You weren't expecting me to ask that, huh?
That's way better.
And so I mentioned briefly to you, and we're going to look for it probably on Wednesday in the during the pig dissection. But the ligament that separates the right and left lobe of the liver can't talk today, is the falciform ligament. So the falciform ligament separates the right and left lobes of the liver. And then it leads down to, we did describe this last time, what's called the round ligament. The round ligament is a remnant of the umbilical cord, and the round ligament is actually considered a mesentery because it did hold vessels from the placenta to the liver through the umbilical cord. And so what we're going to do during the dissection is we're going to cut the umbilical cord, and then what's left on the liver is going to be that round ligament. And then entering the liver, or at the entrance to the liver, we have these three vessels here. One of them is going to be a branch of the common hepatic artery, which is the red one. We have the hepatic portal vein, which the hepatic portal vein receives blood from the intestines, both small and large, the spleen, and although you didn't have to know that vessel, also the stomach. So it receives blood from the intestines, spleen, and stomach in order to filter that blood through the liver before it gets returned to the heart through the inferior vena cava. And then also we have the bile duct as well, which we'll talk more about the bile duct in that pathway when we get to the gallbladder. But your hepatocytes, so hepatocytes are liver cells. They are organized into what are called lobules. So lobules are a little, 1, 2, 3, 4, 5, 6 is a hexagon. It's a hexagon of liver cells. Okay, so they're organized in these lobules. And so each corner of each lobule contains what's called a portal triad. And the portal triad is essentially a hepatic arterial to eventually deliver oxygen and nutrients to the liver, a hepatic portal venule to deliver blood from the intestines and stomach and the spleen to the liver, and a branch of the bile duct. I'll say branch of the bile duct, or what will eventually become the bile duct. So at every corner of these lobules, there's going to be a red vessel, a blue vessel, and a green vessel. And one thing to know is that now in the middle of each lobule, and I'll put that over here, the middle of each lobule has a central vein. And so the blood moves towards the center of each lobule. So it goes through the different hepatocytes, through these lobules. Those hepatocytes are working to filter that blood. And then it gets put into the central vein, which eventually leads to hepatic veins and eventually to the inferior vena cava to return that blood back. And then bile is getting sent out from these hepatocytes out to the portal triad to eventually secrete that bile out and eventually make its way to the small intestine. Questions about these hepatocytes and lobules? Okay. So blood is making its way in for filtration. Bile is making its way out from the hepatocytes that made the bile. So these are all the different functions of hepatocytes. It produces bile from bilirubin and cholesterol derivatives. And if you remember, bilirubin comes from comes from the heme breakdown of red blood cells. Also, it's going to do the conversion of glucose into the storage form, which is glycogen. What hormone triggers us to store glucose as glycogen? Insulin. So this is triggered by insulin. Well, one thing you should know about BIOL that we'll talk about more later is that BIOL emulsifies fat. And what it means to emulsify fat, all it does is take large globs of fat and makes smaller fat droplets. Okay, so it just makes big pieces of fat into smaller pieces of fat. We're not making it any more simple. It's not an enzyme, so it's not going to break it down chemically. All it is going to break it down into smaller pieces. This is where we take amino acids and make them into proteins like clotting factors, like globulins, including immunoglobulins, albumin, fibrinogen. So the different proteins that we learned about during the blood chapter that the liver makes, that's happening here at the hepatocytes. The liver also stores fat-soluble vitamins like vitamin D and K and E. So fat-soluble vitamins, because they are stored, you're more likely to overdose on them if you take too many. Water-soluble vitamins, if we have too many, we just get rid of them in our urine. So if we have too much vitamin C, we're just going to urinate whatever we don't need out. But all fat-soluble vitamins are actually stored, so you have to watch your intake that you're not eating or intaking or ingesting too much of those. It's going to convert ammonia into urea. Ammonia is a waste product that can be toxic in high levels. So it is detoxifying that ammonia into urea, which can then be released through our urine and our kidneys. It also is going to detoxify alcohol. So it converts alcohol into a version called aldehydes, and those aldehydes get converted into sugar. Extra sugar gets stored as fat, which is why if you drink alcohol to excess, you will gain weight, because that extra sugar is going to be turned into fat, which is going to, for men, it'll create a beer belly, and yeah. And then also at the liver, we have macrophages that are there to patrol the area for anything that doesn't belong. Phagocytize old red blood cells for recycling and aid in the immune system process. So I know you have seen questions like this before in the last exam. So if I were to ask you about like what the effects are if you have a diseased liver, these are all the things that are being affected. Okay, you won't be able to produce bile. You won't be able to store glycogen. You won't be able to make proteins. You won't be able to store fat-soluble vitamins. You won't be able to detoxify. So when you're doing like the select all that apply or A and B and not C or all of those things, make sure that you're taking into account all these different functions. So all of these will be reduced if you have a diseased liver. So bile ducts collect bile. So this is a process of bile function as well as recycling. So bile salts are secreted into the duodenum, which is our first part of our small intestine. As bile salts travel through the small intestine, they are going to emulsify the fats. So they're going to start off our lipid digestion by making the big fat pieces into smaller fat pieces. 95% of our bile is reabsorbed by the ileum. So we are recycling a lot of our bile. Okay, we don't really get rid of it. We just recycle it all and reuse it all over again. And then the reabsorbed bile salts travel back through the hepatic portal vein to the liver, where they are recycled. Only 5% of our bile is remade or reproduced. 95% of it is recycled. And so when you have high cholesterol, the way that we get rid of it is that your cholesterol meds will actually bind to the bile salts. That way they can't be reabsorbed. if we have cholesterol binding medications binding to the bile or the bile salts that have cholesterol in them, then they're too big to get reabsorbed. Okay? They cannot fit through those capillaries, and so what they do is they keep moving on the digestive tract, and then we eliminate them or poop them out. So next is hepatitis, which is inflammation of the liver. There are viral causes, and then we'll talk about non-viral causes. Hepatitis A is foodborne. The effects are usually mild, or symptoms are usually mild. So foodborne meaning it's usually caused by shellfish that's prepared improperly. And so it's easily treatable. But then we have hepatitis B. Hepatitis B is bloodborne, so it can be spread by use of sharing needles. It could be by sexual contact. It can even be from mother to baby as well. But it is bloodborne. Inflammation leads to cirrhosis. It kills very quickly. And vaccines are given to newborns and anybody who's working in a hospital. There are a couple different forms of Hep B. It can be either acute, which is a rapid onset, or it can be chronic. And infants, because of their underdeveloped immune system, are more likely to develop chronic hepatitis B. And most adults, Hep B only lasts less than 6 months if treated. They would do a blood transfusion for either Hep B or Hep C, I believe. They're both bloodborne, but I'll double check on that. We're only focusing on these three, but hepatitis A through F exists. Okay, but we're only talking about these three. Anybody who works in a hospital has to get an Hep B test. They have to be vaccinated, and they have to check their antibody titers to make sure they're at a certain level so they're not infectious in a hospital setting. Hepatitis C is also bloodborne. Inflammation leads to cirrhosis as well. It's slower and doesn't kill as fast, but the treatment for this would be a liver transplant, which are very hard to get. The hepatitis C is the most important infectious liver disease. Now, there is an antiviral treatment that's available for this. And before I get there, you should know that 4 million Americans suffer from hepatitis C. And about 10,000 die annually from hepatitis C. And there is a really effective antiviral treatment. So there's an 8 to 12 week drug therapy that's available. That can be very effective, but it's very expensive. I want you to guess around how much this 8 to 12 week therapy is for hepatitis C. It can range, if you're using name brand medication, it can range anywhere from $40,000 to $90,000 without insurance for this 8 to 12 week therapy. The lowest you can get it using a generic brand is about $20,000. So very, very expensive for this life-saving therapy. That doesn't need to be that expensive, but it is that expensive because it can be that expensive. Huh? Companies, people who want to sell it at that price, yeah.
But even the generic brand though, it's just
Even the generic brands, but even generic brand company, they're still trying to make money. And they sell it because they can, because it's the one, it's like the limited effective therapy that there is. So you're going to fork up if you want it, or have good insurance if you want it. It's insane. It doesn't need to be that much, but it is. I'm curious. I need to look up how much it is in like other countries that have better health policies. There are non-viral causes of hepatitis as well. Alcohol being one of the major ones. Alcohol, because of the sugar that gets made, excess ingestion of alcohol creates fatty deposits on the liver. Also, hepatotoxic chemicals that you may be exposed to in the workplace can cause hepatitis, non-viral hepatitis. So people who work in like dry cleaners, dry cleaning solvent has hepatotoxic chemicals. If you work in plastics productions, herbicides, industrial chemicals, all have hepatotoxic chemicals, which is why you would have to like wear certain gear to make sure that you're not inhaling too much of that product. Pain relievers are known to cause hepatitis if you have them in high amounts, especially if you pair them with alcohol. And then certain prescription meds like antivirals or corticosteroids can cause hepatitis as well, because your liver is working hard to detoxify your body from them, and then can end up being overworked and causing hepatitis. This is showing you cirrhosis of the liver. Cirrhosis is the last stage of inflammation. So these hepatitis forms can eventually progress into cirrhosis. So last stage of inflammation. So hepatitis leads to cirrhosis. And what happens with cirrhosis is you have the replacement of damaged tissue with scar tissue or fibrosis. Questions about cirrhosis? Okay. It does cause something called ascites. Ascites is the accumulation of fluid in the abdomen. Why ascites? Ascites is a sign of cirrhosis, and why this happens is because without a healthy liver, you're not making enough albumin. And albumin is the protein in the blood that attracts water towards the blood. And so if you have low albumin production, water is not attracted to the plasma as it should be. And so that water fills up other spaces, including the abdomen. So you would have to get that drained regularly if you are someone with cirrhosis. Now, ascites can be caused by other things. You may have seen commercials with children like this. But this ascites is caused by something called kwashiorkor. But it's kind of the same concept. So children or people in general who are malnourished and they're not bringing enough protein in their diet, then they don't have enough amino acids to build the albumin, and therefore it causes ascites. So this is ascites, but for two different reasons. It could be from cirrhosis and not having enough healthy liver cells to make enough albumin, or it could be from malnutrition where you're not bringing enough protein and therefore not bringing enough amino acids in to actually build the protein albumin. Cirrhosis can also cause hepatic portal hypertension. So with the liver being so fibrosed and damaged, it's not being able to bring in enough blood to do that filtering job that it's supposed to do before giving that blood to the heart. So what ends up happening, because there's so much scar tissue throughout the liver, the blood backs up to where it came from. And what you end up with is bloody stool, and or bloody vomit. Because what ends up happening is that it backs up to where it came from, so the spleen and the small intestine, large intestine, and the stomach. And then that blood has to go somewhere. And a lot of times it will escape to the veins of the esophagus, causing varices or extended veins, and then they can burst and cause bleeding in the esophagus. Or the same thing down the intestines and into your feces, and cause bloody stools as well.
You can also bleed out from the liver.
Yeah,
Broken down.
yeah. So this is showing varicosities within the abdomen. So you can see the distended veins here from the backing up of the blood, and those can burst, causing internal bleeding. So questions about cirrhosis? Okay. Alcohol is a very, very, very dangerous addiction. So the next one is the gallbladder. So the gallbladder is a thin-walled muscular sac on the inferior surface of the liver. It is snuggled within a fossa. So not today, probably we'll get to it on Wednesday. But on Wednesday, when you get to the liver on the pig, you can actually put your scalpel or your probe right underneath the gallbladder in that fossa and reflect it up so you can kind of pop it out of place so you can see the gallbladder. As far as flow goes, so the liver makes the bile, the gallbladder stores the bile. So we have right and left hepatic ducts, and so the bile from the right and left lobes of the liver will travel down the common hepatic duct. And then if we're not currently eating a fatty meal or don't need the bile at that time, then it goes through the cystic duct and then gets stored in the gallbladder. Okay. Then when it's time to use that bile, it goes through the cystic duct in the other direction and then down the bile duct and eventually to the duodenum. Say it again?
The arrows going back.
Okay.
out of the bile.
So the right and left over here, this is the coming from the right and left lobes of the liver. So they're making the bile. But if we don't need the bile at that time, it's going to go down the common hepatic duct and then reroute through the cystic duct and get stored in the gallbladder. And then when it's time to use that bile, it goes from the gallbladder through the cystic duct and then down the bile duct. Yeah.
How does that process work for people who have their gallbladder removed?
So if you have your gallbladder removed, your liver's still making bile, but we don't have a storage for it. So you have to accommodate your diet and not eat as many high-fat foods. Because what's going to happen if you end up having a really high-fat meal without a gallbladder, that fat's not going to get emulsified the way that it should, and your enzymes are not going to break it down the way it should, and you'll end up with like oily, gross stools, which are not comfortable. And digestion won't be very comfortable if you're not able to properly break down those fats. So you have to make some lifestyle modifications when you don't have a gallbladder. Clinical note on cholecystitis. Cholecystitis is the inflammation of the gallbladder. The scientific name for the gallbladder is the cholecyst. And so cholecystitis is usually caused by gallstones from bile causing irritation or pain. And so gallstones are soft stone-like structures formed from cholesterol mixed with bile salts. So this is usually caused by too much cholesterol or too few bile salts. And that allows the cholesterol to crystallize. So if the cholesterol doesn't have anything to bind to, so if there's not enough bile salts, and that cholesterol is left to stay in there and concentrate, it'll eventually crystallize, causing stones, and then that can cause blockages through these ducts, which is very painful. Okay. So when the gallbladder contracts after a meal, a gallstone may block the cystic duct, common hepatic duct, or the papilla that it exits from, the major duodenal papilla. And that's going to cause some pain. That's a large stone scraping its way through a very thin tube, which is not fun at all. Kidney stones, gallstones, they're both horrible. And so what can happen, it's going to block that duct, and you can't have proper flow of bile through that duct. And then we'll talk about what effects it can have on the pancreas a little bit later. Risk factors include being female, especially if you are a fertile age female, anywhere from 20 to 40. If you are overweight, or if you lose weight really rapidly. If you lose weight really rapidly, and you're not eating as much, and your bile stays in that gallbladder, it will eventually concentrate, creating crystals, and then you're going to get blockages. The treatment is a cholecystectomy, or removal of the gallbladder. Other treatments include lithotripsy, which is basically using ultrasound waves to break up the gallstones into smaller pieces. Laser treatment, same thing. We're going to use a laser to break down the pieces of or the gallstones in general. And then certain drugs can be used to break down the gallstones. So all these things are to break down the crystals. Okay. I'm going to go through and get to the end. We've got 10 minutes before the next class comes in. This is a really cute cartoon. The liver says, "What is it, gallbladder? Can't you see I have a lot to do?" And he said, "I make these. You made stones? You're just supposed to hold what I give you. Get out, go on." And now he's all sad because he's proud of his stones that he made. All right, so the pancreas, its exocrine function is to produce bicarbonate to neutralize the acidic of the stomach. It's an alkaline solution. And then also enzymes, lipases to break down fats, amylases to break down sugar, which is why it's important that you differentiate salivary amylase from pancreatic amylase. We have two different sources of amylase. Trypsin or proteases to break down protein, and then nucleases to break down nucleic acids. We learned about about cystic fibrosis when we learned about the respiratory system, which causes a thick, salty mucus. And what can happen is that thick and salty mucus is not only going to happen in your respiratory tract, but everywhere where mucus is being produced. And so your digestive tract is one of them as well. And so what can happen is the mucus can actually block the pancreatic duct. And so we'll talk about next time how that can actually lead to pancreatitis. Because what's going to happen is if the enzymes can't make its way out, then they leach out into the pancreas itself, and those enzymes start breaking down healthy tissue in the pancreas because of that blockage due to the mucus production. I'm going to go really quickly through these hormones, and then we'll talk about them again when we get back. But the hormone production at the small intestine is going to start from the chyme in the stomach entering the duodenum, which we talked about with the intestinal phase of the gastric secretions. And so we have enteroendocrine cells in the duodenum. They're going to produce intestinal gastrin, which is going to finish off the last of the secretions from our stomach. So I'm not going to go too much into that because we already talked about that. But what do we call cells that produce gastrin? What's our nickname for them? G cells. But again, it's going to cause the parietal cells to finish off their secretions of hydrochloric acid in the stomach. We also have a hormone that's being produced by these same enteroendocrine cells, one of them being secretin. Secretin causes the pancreas to release bicarbonate, which is going to neutralize the acid of the chyme as it moves through the duodenum. It's also going to target the liver to get the liver to secrete bile. Those are the two targets for secretin. Also, when chyme from the stomach moves into the duodenum, those same enteroendocrine cells are also going to produce a hormone called cholecystokinin. Okay, cholecystokinin can be abbreviated to CCK. We can still abbreviate hormones like we could before, but if you spell it correctly on an exam, I'll give you an extra 1/4 point. But it has 3 targets. One of them is the pancreas to produce all the rest of its secretions. So secretin causes the release of bicarbonate, but CCK causes the release of the lipases, pancreatic amylase, trypsin, and proteases as well. So all the different enzymes that are being produced. It's also going to target the smooth muscle of the gallbladder to contract to release the bile into the small intestine. And then also we learned about that hepatopancreatic sphincter where the bile duct and the pancreatic duct come together. It's going to cause that sphincter to relax so that we can release those contents into the small intestine. And that's it, you know. Not too much, but we'll talk about it again when we come back on Wednesday. Hey.